So the big topics on this exam are the immune therapy. Yeah.
I just have a quick question. Do we have, so our exam was moved from like next Monday to next Thursday.
Oh.
Do we have farm class on Monday?
No. Nothing next week.
Okay.
Yep.
So everything from chemo stuff
to today. Yes, okay. That's correct. Yep. So yeah, immunotherapy, ophthalmic, and the respiratory stuff today, and then chemotherapy being a small part of the exam. Yep. Okay. And then the anemia stuff kind of lumped into there too. All right, so reviewing what we talked about last time we met in person, the immunotherapy stuff. Here we have a 56-year-old male with chronic heart failure. He was recently given induction therapy and received a heart transplant. He is recovering from surgery, and it is time to start a maintenance regimen in order to prevent rejection. Which of the following combinations is most appropriate? You guys are like, I don't remember. Anybody remember a class? Okay, so they all have prednisone in it, right? So that's a gimme. I didn't even, you can't even roll one out off of that, so sorry. The rest of it you want to figure out and mix and match your classes so you get the two other main classes, and those are going to be, anybody remember their names? What one of them might be? Kind of sounds like calcium, no, calcineurin inhibitor. So a calcineurin inhibitor and an antimetabolite. So choice A is incorrect because it contains a azathioprine, which is an antimetabolite, but sirolimus, which is an mTOR inhibitor. So you have a couple different mechanisms there that you can alternate in with mTOR inhibitor, and we don't start with that one usually, unless there's a really good reason to. So that's not correct. Choice B contains mycophenolate, which is Cellcept, and cyclosporin. So mycophenolate is an antimetabolite, and cyclosporin is a calcineurin inhibitor. So you do actually have two there that would be effective, so that is the correct answer here. Cyclosporin and tacrolimus are both calcineurin inhibitors, and TAC is a calcineurin inhibitor. Basiliximab would be something you might use for induction or for salvage. So again, for the MABs, I'm not going to really ask you about induction therapy, but if you see them come up on a question like this, I do want you to know that that's not a standard transplant or anti-rejection type therapy. Okay, glaucoma. So this was the online lecture last week. So we have a 67-year-old female in your clinic for an annual physical. She reports feeling well, but has been experiencing restricted field of vision based on her reported symptoms in your physical exam. You decide she probably has mild glaucoma. You want to have her follow up with an ophthalmologist, but you're okay starting her on something today. She is on the following medications. So she's got a couple different things going on here. I'll try and be really clear until we actually talk about these medications, what they're for. At some point in the class, I'll kind of stop dropping some of those indications, so you'll be expected to know what those are. But we, of course, haven't covered any of these with the exception of her talking about inhalers today. But anyway, the point is I gave you heart and blood pressure, so those should sort of stand out. And what class do we not like to use in eye drops for people with heart conditions or people with blood pressure issues? Is there one we'd like to avoid? Anyone? I'll give you a hint. It's like the same as this one right here. Does that help anyone? Beta blockers, yeah. So ophthalmic beta blocker presentations, we usually try to avoid that as first line in somebody who already is on antihypertensive. They can get a compounding effect, and they can get some hypotensive additive effects from the eye drops, even though it's probably minimal. And if somebody didn't have any heart conditions, I wouldn't really worry about it a lot. But because she does have some blood pressure issues, I probably wouldn't go overboard on it, especially with beta blockers. We'll talk about this in the next module, but beta blockers they lower heart rate. They prevent the heart rate from increasing. So if people get too much, they can kind of feel crummy on them and really fatigued. So there's a fine line to walk with beta blockers, and that's why we're pretty careful with them. So the way to remember it, even though we haven't talked about oral beta blockers yet, we have the same nomenclature system as the ophthalmic one. So if you remember this LOL end name, you can see that. And again, I'll tell you it's for heart or blood pressure. But if you see heart or blood pressure, that should be kind of a glaucoma, not a contraindication, but a little bit of a red flag that would lead you down the path of maybe I don't want to start with a beta blocker in this patient. So you have a couple options to pick. Does anybody have a preferred choice here? What's our first line agent for glaucoma? Prostaglandin, yep. So which one of those is a prostaglandin? Yep, bromatopros. So they all in pros. It's kind of easy to remember what they are from a class perspective. So yeah, we usually start with the prostaglandin. They have the best evidence. They're usually the best tolerated. It's a big side effect to consider with prostaglandins. If you have blue eyes, so yeah, they can cause some darkening pigmentation of the iris. Not in all patients, and certainly not worth withholding them if the person has really bad glaucoma, but it is something to consider. They can also cause increased eyelash growth and stuff like that. I think I talked about the cosmetic use a little bit, so that can also have a backlash effect too. It can make people uncomfortable where their eyelashes are kind of poking them. But other than that, they're really well tolerated medications. There's virtually no contraindications to using them. So that's why they basically replaced beta blockers, which are kind of the old guard as first-line glaucoma therapy as the first-line therapy. So it's really common to see people on glaucoma on these. They're probably the most common eye drop glaucoma medicine you'll come across. Betaxolol is a beta blocker, so that's why I just talked about why we wouldn't use that. Dorzolamide timolol combination. Usually wouldn't start with a combo therapy in someone. This would be a good thing you could like add on to somebody's vermatoprost regimen or prostaglandin regimen as an adjunct therapy, a second line choice. And cardiac or side effects, I kind of already talked about these. So we've got cardiac effects, hypotension, bradycardia coming off with the beta blocker. Orthostatic hypotension, drugs that block alpha receptors, so like dorzolamide would be one like that. Brown discoloration of the iris would be vermatoprost. We talked about that as well. Fixed small pupils. I don't have that on here. That would be more of a cholinergic type medication, so the class we really don't use because it really restricts vision. It's not as convenient for people to take. Yes, it lowers intraocular pressure, so you can preserve some optic nerve damage, but you can't see all that well on it, so it's kind of a catch-22. And then olopatadine or Pataday, that's an antihistamine product. So that wouldn't have any role in glaucoma, but it could be used as an allergy-related medication. I think that's over the counter now. Okay. So again, just some examples of questions and concepts to focus on as we talk about, or as you study for exam. But let's talk about inhalers today. So I'm going to show you some inhalers. You guys had a talk with a respiratory therapist at some point, right? Already? No? Maybe they canceled that. No? Okay. Did somebody tell you about inhalers? Somebody did? Okay. Well, I'm going to talk about them again. I have some inhalers here. If you want to see them at the break up close and personal, you can, but we'll go through them. I don't think you can hear inhaler compliance too many times just because it's one of the key steps with giving somebody respiratory medications is making sure they're actually using them correctly. So there's basically 3 different types of inhalers on the market, but really 2. So there's meter dose inhalers and dry powder inhalers. Soft mist inhaler is kind of a new thing that's sort of anyway, it's sort of like an MDI, but it's a little bit different in how it delivers, and I'll talk about that in a second here. But for all intents and purposes, you have an MDI and DPIs. So meter dose inhaler is kind of your standard inhaler. This is like what people think about as a rescue inhaler, an albuterol inhaler. It's got a propellant in it. This is placebo, so I'm not drugging myself right now. This is how most of them look by far and away. It's a really simple device. It's got a canister that goes in it. Comes out, so like the patient, if they get it, I don't know if it's in your kid, if it's in your kid's purse, if it's in your purse and your kid's like gummy bears get stuck in it or something, you could take it out and run it through the dishwasher or something. So they are nice like that. They usually have a dose counter on them. I'm trying to turn this thing on here if I can figure out how to use the computer. And I can't. So I don't know how to use that. Anyway, if you want to see it, there's a small dose counter on here that tells you how many are left in it. Like, for example, this one comes with 200 metered actuations. This is basically designed to mimic a Ventolin inhaler, which is a brand name of albuterol, and albuterol is a rescue inhaler. The only point in the counter is that it's not designed to deliver you a certain number of doses for a month interval or anything. It's just medicine you need when you need it. You shouldn't really take an albuterol inhaler every day, so these should last a patient a while. But the nice thing about the counter is otherwise you really don't know how much is left in it. You might be able to feel how heavy the canister is because certainly the liquid will dissipate over time as you use it. But otherwise, it's a little bit difficult. And you can see I just messed with it, and I put it right back in, and it shoots out just fine. So they're really easy to use for the most part. And again, you get a nice counter on the back there. Dry powder inhalers are a little different. Here's a couple different examples of them. What they are is all essentially the same type of mechanism, but they just work a little bit differently. There's different patents out there with companies that have them. Glaxo owns most of the patents on them. So Glaxo has 2 products on the market, Discus and the Ellipta product. The Ellipta product is the newer one. That's the one they market heavily now. Actually, our system uses this. It's cheaper than the Discus, and I think it's a lot better. So I'm not trying to advertise for Ellipta products, but anyway, I do think they're better. So the Discus products, like Advair, you guys heard of Advair, that's what this is. This is, again, a placebo. Basically, you open it up like this. It opens a small window in the device. That window, when you pull this back, you release an opening, and there's a small amount of powder in there. You inhale that in, close it when you're done, and then it decreases the dose counter on the outside. So you can see this one, while it's kind of a clever device, there's a little foil blister strip in there that dispenses your dose, so it punctures it as it goes through. It's a little bit of a manipulation. You got to pull it, open it, do it like that. The Ellipta products are a little bit streamlined. So you've got this thing on the top. It's nice and wide. So if you think about like an elderly diabetic patient, whether they can use this or not, it's going to be a lot easier for them to grip something that's thicker than something like this that has a little bit smaller of a grip to it. But ergonomically, these are a little bit better designed. So anyway, this thing pulls down. One step, it opens up the window, and you would inhale off of that. It just closes like that. So it's a little bit more streamlined. Same concept, though. It's dry powder in there, and it's puncturing some kind of a window. And then you've got this is actually real medicine in here, so I'm going to try not to breathe it in. But this has a dose counter on the front, and then this one has a little tiny dose counter here. So they actually made the dose counter a lot bigger on these Ellipta products. So again, for people with eyesight issues, easier to see how many doses you have left. And that's really helpful for adherence purposes and understanding like how much you have left in your inhaler. Do you have extra inhalers at home? What's available or not? Okay, common sense doesn't always apply to inhaler usage. I think a lot of people are like, oh, you just breathe it in and that's it. It's a little more complicated than that, unfortunately. So let's talk about this in more detail. I'll show a video here. Let's see here. So I wrote all of the descriptions or the instructions out here, but I think it's easier to watch it. And I froze the computer. Let's see if this recovers or not. Okay. One of these days I'll get this thing back up. All right, you have it in front of you. We'll talk while this goes on. So the video, it just shows you how to use the MDI. There's not a lot to think about. I mean, I guess it is pretty self-explanatory how you use an inhaler. You breathe it in. But the question is, how do you do it and what do you do differently between the two? So if somebody has like a dry powder inhaler that they take as a controller medication like Advair and an albuterol inhaler that they take as a rescue medication, that's different the way they use them. Biggest difference between how you use them is about how fast you breathe. So with a meter dose inhaler, it's a little bit of a sustained process. So you want to do a deep, slow breath over a few seconds while you're inhaling. That'll ensure it gets into the lungs. If you do a really fast breath, this is a little bit of a heavier because it's got liquid propellant in it. Sometimes it can just deposit sort of on the back of the throat and you'll end up swallowing it instead. So it's really important to kind of have a slow, deep breath. And if you want to do it perfectly, you should start inhaling a little bit before so you'd start breathing like this and do something like that. It's a little scary. Hopefully that is just placebo, right? I don't know what they put in there. Am I going to get one of those vaping related diseases? All right. But the point is that start breathing a little bit, get the lungs flowing so that when you shoot it in, it goes down. Most people use these with a spacer. I don't have actually, do I have a spacer? You guys know what spacers are. It's something you would put on. You could actually use a cardboard box if you really wanted to. There's nothing complicated about them. They're just a chamber. So you would actuate into the chamber, and then once there's stuff in it, you would breathe it out. So it allows you to control your breath a little bit better than having to time it with the administration of the actual device that way. There's different kinds out there. A lot of them are like plastic things that look kind of like this. They're a chamber that the inhaler hooks in, and then it's got a mouthpiece on one side. We use really cheap ones out of the hospital. They're just like a piece of plastic tubing. It's all the same concept, really. There's not really one better than the other. Some of them are probably more durable and better for long-term use. And certainly, I think people associate them as just being for kids. I actually think adults can benefit from them too a lot of the times, because these aren't, like, I think you guys seen the Goonies when he just like puffs really hard on his inhaler. That's really bad inhaler technique for an MDI. So if people think of that in their head, they're in for a little bit of surprise when you find out actually how to use an MDI. All right, the flip side of that, the DPI, is the opposite. So you want to inhale this fast and deep breath, so not slow. If you inhale this slowly, because it's a powder, it has the same effect as if you inhale the MDI fast. It's going to stick to the back of your throat, and it's just going to swallow it. So you're going to be swallowing a small dose of steroid or beta agonist or whatever you're administering here. So that's really the biggest difference here. And other than that, I don't really care you know too much more about this. It talks about like how long to hold your breath for and everything after that. I think a lot of this stuff is like tell patients to hold your breath for 10 seconds. I think the point of that is so you just aren't immediately exhaling the product out. So just try, and it's have to be 10 seconds. Is 5 okay? Probably tell people 10, just to hopefully people hold their breath for a little bit after doing it. But for both of these, you have to get the drug to the site of action. So if you aren't using it correctly, then you aren't getting the medication into your system, not treating the disease you're intending to treat. So that's why inhaler compliance is really, really important. Okay. The mist inhalers, or these new ones, are branded as Respimat products. So if you see something that's like Spiriva Respimat, or I don't know, that's one of the brand names. So again, it's an advanced MDI that has slower moving particles. It's supposed to last longer in the pulmonary vasculature, so it sticks around in the lungs a little bit longer. They had to reformulate a lot of these MDIs maybe 10 years ago or so, because they had chlorofluorocarbons in them, which are apparently greenhouse gases. And who knows if enough inhaler actuations can actually lead to global warming, but I guess we can never be too careful. So they, and maybe they're harmful to humans too, I don't know. That's probably more of the pressing cause, right? So if you have something in here that all these inhalers got reformulated a while ago. So I'm not sure if this was really any environmentally better. I think there's lots of strict regulations on what can be an inhaler propellant nowadays. But anyway, the Respimats say that they're more environmentally friendly. Clinical trials show more efficient drug delivery and better adherence. Most of this has to do with it just lasting longer. So you might be able to give something once a day versus twice a day. And that's really key with inhalers. A lot of times it depends on how long acting the medication is and how long it sticks in the lung. So for example, an albuterol product is like, you get 4-6 hours out of it. Some of the Brio products you get a full day's activity out of. So again, we'll talk about these more as we go through the actual drugs. All right. Any questions on inhaler use or compliance? I'll set these up here. And again, I just warn you, this I sterilized this very well with a lot of alcohol. But it is a real inhaler that expired. The patient didn't actually use it. It was just one that came back down within the date and it expired. So, okay. But just in case, you never know. You do, because the dose counter. All right, so short-acting beta agonist. So this is, again, like the albuterol drug that I was just talking about. Albuterol is the most common product in this class, and it's really the only one to consider for the most part. Yeah? Oh. That's really weird. Oh, somehow I clicked a freeze screen button. There we go. I didn't know that was an option. Okay. All right. So you have, I don't know how to get that thing off the bottom. Oh well. So short-acting beta agonists. Albuterol is going to be the primary drug here. Almost anyone with any respiratory disease, and sometimes they prescribe it for other things like a short-term cold or things like that. But are going to be prescribed a SABA, and albuterol is going to be the primary one. There's a lot of different brands of albuterol out there. There's ProAir, there's Ventolin, there's, I don't know, I'm probably missing a whole bunch. But anyway, there's a bunch of them. But for the most part, it's probably one of the cheapest inhalers you can get, which is a little bit of a blessing and a curse. It's nice because people can afford to keep a rescue inhaler with them. It's bad because sometimes that's all people can afford. So that's all they're using, and that's not good management of any of the disease states we're going to talk about. There is an alternative to albuterol called levoalbuterol. One of the things about having a SABA, or short-acting beta agonist, is, remember, beta receptors hit the lungs and the heart. So if you're hitting the lungs and it's not a super selective drug and it gets into the systemic circulation, you're going to cause increased heart rate as well. And that does happen. It'll happen with even a small amount of albuterol. So if you're taking like a few puffs during an asthma exacerbation, you're probably going to feel your heart rate elevate pretty fast. And that's because stuff absorbs really quickly through the pulmonary vasculature and gets into systemic circulation quickly. So in this case, some people get really jittery on albuterol. So the company made a product called levoalbuterol, which is the left enantiomer of albuterol, and they claim it doesn't cause as much jitteriness. I don't really believe this myself, but there are some patients out there who swear by it. It is really expensive compared to plain albuterol, so we try not to use it. But occasionally you'll have somebody who just says that they won't use regular albuterol. Again, it's rare, but it does happen. Both of these products are available not only in inhaler form, but also in nebulizer form. I'll talk about nebs in a few slides here and what the difference is there. But that's nice just because nebs are, well, the gist of a nebulizer is it's a liquid given through a nebulization machine, and it's really cheap compared to giving an inhaler. So like if you have somebody come into your emergency department or is in the hospital, you want to give them 1 dose of albuterol, that costs like 60 cents versus an inhaler of a albuterol inhaler probably costs $20 or something like that. From a cost perspective, it's nice to give single doses that way. It's also nice for kids because you just put a mask on them. You run the thing, well, I shouldn't say just because it's going to be pretty awful. Tried this on my daughter. She had a really bad cold last winter, and it was like, I think she actually went into a mild panic attack when I put it on her. She was breathing a lot worse after she was screaming than from the actual cold, so I decided it was a waste of time and didn't comply with the doctor's instructions. Sorry. So anyway, yes, the idea is you can put it on a kid, and the kid doesn't have to worry about inhaler compliance. They just let the nebulizer go through its cycle, and they breathe normally and would inhale it that way. Short-acting, again, SABA, short-acting beta agonist, 4 to 6 hours. Again, regular use, not recommended for these medications. And they do correlate frequency of use with disease severity. In fact, it's one of the asthma metrics as to where they stage you in asthma disease is how often do you use your rescue inhaler. So that's always a question you should ask patients when you're assessing their respiratory conditions. How often are you using it? It's a standard question. All right, the LABAs, or the long-acting beta agonists, is the exact same concept as a SABA, however, it lasts a lot longer. The flip side of that is some of them take a bit longer to get started, too. So there's salmeterol, formoterol, arformoterol, indacaterol, olodaterol, vilanterol. There's a lot of them. Again, these are all beta drugs, so they all end in OL, which makes it kind of easy to remember which one's the beta component. A little bit different than the beta blockers, obviously different mechanism, the opposite, but still kind of a similar nomenclature. So these are all different parts of, some of them you can get by themselves, some of them you can get in combination. Combination products are really popular in both asthma and COPD, so we'll talk about those and where they're useful. But these have a role in both areas. It just depends on when you start them, depends on the different disease, I should say. Almost all of these are dosed twice daily. One of the other advantages of these Ellipta products and the Brio products, and I'm not sure if it's what they're putting it in or the actual drug itself sticks around longer, but vilanterol is only a once daily medication. And it's one of the only long-acting bronchodilators, which is essentially what the beta agonist is doing, to be once daily. Versus the older products like Glaxo, the Discus products, are all BID. So it's a little bit more convenient from that perspective for most patients. And you get the same effects with once daily versus twice daily. Yeah.
Should we know like what separates each one of these things, or when you use it? Is that
no, I'd just be able to recognize what am I trying to say? Long-acting beta agonist is. Yeah. The one difference that I would know on this whole slide would be formoterol, because there's a recent change this year with the Asthma Guidelines that I'm going to talk about, where they actually recommend using this as a PRN medication. It's been long thought of as useful as PRN because it's the only one on the slide that has a fast onset. Onsets in 5 minutes versus the rest of them take like an hour or two to start working. So theoretically in an exacerbation, this would probably be just as effective as your albuterol inhaler, with the exception of it's going to last for 12 hours. So you aren't going to have to keep redosing yourself on it. So there has been some updates there, and I'll go through that in more detail. But that's the one I would know as different than the others from a like a clinical decision-making perspective. All right, next group is the inhaled corticosteroids. We already talked about corticosteroids in detail, but they block late phase reaction to allergens, and that's basically their mechanism to why they help with reducing airway hyperresponsiveness there. They're first line for long-acting therapy in asthma. After you want to rinse your mouth, swallowed corticosteroids can have systemic effects. So that's why, again, the compliance is really important. If somebody's rinsing their mouth, they should spit instead of swallow, because if they swallow it, they're probably just swallowing whatever powder is left in their mouth. If they do have corticosteroid left in their mouth over long term, it can cause candidiasis, and that's one of the side effects of just weakening the immune system locally. It doesn't have any role in acute treatment, so a corticosteroid does not do anything acutely. So when people tell you that they take certain medications as needed, it's kind of a red flag. Again, I'm going to talk about why that's changed slightly with asthma, but especially for COPD, if somebody has like a combo inhaler, they're like, I just take it whenever I feel like I need it. That's not good compliance. That's, nope, you're either not on the inhaler because you don't need it at all, or you should take it every day. One of the two. It's not somewhere in between. Steroids do take some time to see benefit, as I've talked about before. And some people consider supplemental calcium. If you remember, we talked about osteoporosis and osteopenia being one of the long-term side effects of steroid use. I personally don't think there's enough systemic absorption regularly from an inhaled corticosteroid to cause concern for this. However, supplemental calcium is virtually benign in almost all patients, so it might be worth it, especially if you have a patient who's maybe an older postmenopausal adult female. They're probably going to be at risk for that anyway, so they should maybe be on calcium vitamin D as is. Okay, so here are the different inhaled corticosteroids on the market. Again, I don't want you to really know the differences between these. Most of them end in "-one", like fluticasone, triamcinolone, etc. It's the one that doesn't end in "-ol", if you want to think about it that way too. So historically, all the combo products were just corticosteroid and long-acting beta agonist. However, within the last, I don't know, maybe 3-4 years, we've seen a lot of differences in that. So now there's triple therapy combo inhalers that have, we're talking about antimuscarinics here in a second, and there's different combinations out there too. So you do have to pay attention to what your patient's doing. If they pull out a combo inhaler, don't just assume it's a corticosteroid LABA. But most of them, historically, like Advair, were combinations like that. And again, you can get a lot of these by themselves. So like if you wanted to start somebody on just fluticasone inhaled, like you can start a Flovent inhaler, or Arnuities, the Ellipta product, and there's a bunch of other ones too that are on the market. Okay, so talking about LABA and steroid combinations, again, these are really popular. There's a lot of them on the market. You've got Advair, Symbicort, Dulera, and Brio are all the brand names. And again, they're all just variations of different steroid and different LABA combinations. You'll notice formoterol is used in both Symbicort and Dulera. Fluticasone is used in both Brio and Advair. Symbicort and Dulera have different steroid combinations. So that's how the drug companies kind of get around copying each other. They mix it up a little bit that way. Yes? Trying to think if I give you brand names on this exam. I don't think I do. I think I just give you the generic. So, you know, focus on understanding which one's a corticosteroid and which one's a long-acting. But I will offer you like combination therapies in a question. So I might ask you if you want to start on a combination therapy or change to a combination therapy. While we're on the line of corticosteroids, systemic corticosteroids do have a use in asthma. We usually don't use them regularly. It's basically an exacerbation type thing, and COPD, I should say, both asthma and COPD. So they give a powerful anti-inflammatory response that you aren't going to get with an inhaled corticosteroid alone. We use them in what's called bursts, so like a 3 to 10 day course, maybe up to 2 weeks. Usually a sustained dose and then stopped. You don't have to taper these patients, but some people don't feel comfortable with that, so they will anyway. I'm just saying you don't need to. Remember, 2 weeks is kind of the cutoff. If you go less than 2 weeks on a steroid, you don't really need to taper it. Prednisone, asthma, 40 to 60 milligrams a day, COPD 30 to 40. You don't need to know the dose. It's just showing that we use a little bit higher dose in asthmatic patients than we do in COPD. Reason being is asthma is much more associated with allergic-related response, and that's where steroids have a good acute role. So a lot of times with asthma exacerbations, we'll actually give an IV dose of steroids when they come in, and then we'll start them on an oral dose after that. And that's where methylprednisolone is a common one we give IV for that. Sustained use, remember, adrenocortical pituitary unresponsiveness in times of stress, so that's why we don't want these people on them long term. So the idea is get them through the exacerbation, maybe optimize their inhaled therapy, get them to follow up. If you're working urgent care or ER, get them to follow up their primary so they can adjust their inhalers maybe. If you are primary, look at compliance, look at doses. So I talk about these different inhalers here. You'll notice there are different doses available. Generally speaking, the LABA is the same dose in all the steroids. Or sorry, I'm not talking correctly. The LABA is the same dose in all the different inhalers. Not the same across the board, but you see there's no variation. So for example, like with Advair, you can get 3 different strengths of corticosteroids. So that's the corticosteroid component. The 50 micrograms is the salmeterol. So that's fixed. You can't change that. So you can adjust the steroid component up and down with these. Symbicort, Dulera, and Brio all just have 2 options, where Advair has 3. Whether you need that third 500, whether that makes a difference, probably not. But it's there in case you wanted to use it or really thought you needed maybe more steroid for a certain patient. Anticholinergic medications reduce intrinsic vagal tone of the airway via muscarinic receptor inhibition. This decreases some secretions, but more so it's a bronchodilator. So you've got 2 bronchodilators we're talking about. One is the long-acting beta agonist, and the other are the anticholinergic or antimuscarinic agents, often abbreviated LAMA, long-acting antimuscarinic agents. So technically 2 A's, but they cut one out. Long-acting muscarinic antagonist. That's what it is. So it is correct. Sorry. I don't know what's wrong with me. Okay.
Do these have any systemic anticholinergic effects?
They should. They should stick around pretty much in the lungs, kind of like the steroids. You might see a little bit, especially if somebody accidentally swallows some of it. They might get some constipation, some urinary retention, but yeah, minimal. Should be minimal. So again, that's a good segue because this is a nice class of drug that usually has a lot of side effects associated with it, but in respiratory works quite well, and actually is the most popular drugs we give for COPD patients. So most patients, probably 100, well, I should say 100%, but the vast majority of patients, based on evidence, should be started if they're on COPD. If you're diagnosed with COPD, you're going to start them on an antimuscarinic antagonist, so one of these drugs. A couple ones on the market. Tiotropium or Spiriva was the big one for many, many years. There was nothing equivalent to it, which kind of blew my mind because it was like a $10 billion a year drug. Why no one made anything to compete with it was kind of astounding to me, but maybe they just didn't get the research through in time. But the only other alternative to Spiriva was ipratropium, which is Atrovent. And Atrovent is a short-acting anticholinergic. So it's not a LAMA, it'd be like a SAMA, or short-acting muscarinic antagonist. So ipratropium or Atrovent isn't a good long-term agent or a controlling medication. However, it is relatively inexpensive, so sometimes people will use it. If you use it regularly, you have to dose it every 6 hours. So it's 4 times a day. A lot of times people take it in combination with albuterol. It does have a really great role in acute respiratory distress, though. It comes as a product called Duoneb, which is a combination nebulizer with ipratropium and albuterol in it, and that's a really nice dual bronchodilator to give somebody with an acute respiratory distress situation. Outside of that, I don't see ipratropium used a ton. There is a nasal spray out there as well, but that's a different indication, of course. There's 2 new ones on the market, aclidinium or Turdoza, which I don't ever really see that often, and umeclidinium, which is Incrus. And Incrus is part of my favorite, I should really get paid by Glaxo, my favorite Ellipta line of products. So it's like a green version of this. They basically took Spiriva's color scheme and copied it and made their own antimuscarinic. So you got to admire the ingenuity on that one. In fact, they're all green. They all copied Spiriva. That's kind of funny. So basically, let me show you. Do I have a? Yeah, let's look at the Spiriva. So I don't have a Spiriva with me because we don't use them anymore. But I just want to show you how complicated this system was and why I'm really glad it's not what we like anymore. Not to say there's anything wrong with the drug. The drug works great, and if you need something on Spiriva or somebody's insurance only pays for Spiriva, fine. But I would say that there's other better options than this. So what you have to do with Spiriva is you have this little egg-shaped thing, and you open the top like you see here, and then you open the mouthpiece, and then you put a capsule inside of it. So it's a capsule, it's just like an oral capsule, which is the first problem there because people ingest them thinking they have to take it orally. So that's one counseling point. Then once you put the capsule in, you press this little button on the side here that crushes the capsule, releasing the powder. There's a little gray screen on the top that prevents you from inhaling any sharp pieces of plastic, which is nice. And then you breathe it in like you would a dry powder inhaler. So essentially it's a dry powder inhaler. It's just a much more complicated mechanism than the Discuses or the Elliptas or really any other dry powder inhaler on the market. So Spiriva has a lot of issues for people who have difficulty manipulating small components for obvious reasons. You have to do a lot of manipulations to access your Spiriva. You have to handle small capsules. You have to push in things. You have to open up multiple components. It's just overly complicated. So I'm not a fan of the HandiHaler, but again, it was the only thing that was on the market for a number of years. So you will see people on it probably for a while. This is probably a good enough segue as any to talk about inhalers and price. Inhalers are really, really expensive. So like one inhaler, one of these is probably $200 to $300 cash price. Yeah, and even our institutional ones, which only contain 7 doses, are still like $200. So what you're paying for is this complicated delivery system that the company has a patent on. So one of the things people ask me about inhalers is Advair's been on the market for, God, I don't know, 20 years maybe? It's been up for a while. Why isn't there a generic version of it? Because the drugs are generic. This is not. This is a device, and this has a different patent process behind it. So you can't just go out and make your own discus and rip off Glaxo. Glaxo ripped off themselves and made it better. So again, kudos to them, but no one else can really do that. So if you want to make another inhaler, you really do have to kind of think of outside the box. So Pfizer makes Spiriva, and so I'm ragging on them a little bit, but actually they're probably pretty hindered in patent as to what they could actually make without infringing on Glaxo's patents on their inhalers. So that's why inhalers are so ungodly expensive, and why you probably won't ever see that change unless there's pretty significant patent restrictions removed in the actual device itself. Again, the drugs, you'll notice fluticasone is in here. Talked about fluticasone nasal spray. There's lots of applications to fluticasone, and lots of these products have fluticasone in them, but it doesn't mean it's patented, because it's not. It's generic. It's just, again, the device and the delivery system behind it. So a little bit of a difference in how inhalers are approved versus how the average drug is. All right. Did I finish talking about anticholinergics? Yes. So you have some combinations on the market. I talked about, you can't really see this one at the bottom, but this brand name Trilogy is the first one to come out that's a triple therapy. So it contains a inhaled corticosteroid, an anti-muscarinic long-acting, and a long-acting beta agonist. So it has the 3 therapies in it altogether, which is really convenient if you're a person that needs all 3. Most people, probably not, but it is an option out there. And it's once daily, which is, again, it's kind of like HIV meds. When they combine a whole bunch of them together and make it once daily, it becomes a blockbuster medication. So for people with uncontrolled COPD, this is really the only option out there that allows them a once-a-day use. You have another combination that's a newer one on the market called Anoro. And these Anoro and Trilogy are also Ellipta products. So they all come looking kind of like this. They just have different medications in them. And Anoro is the first combination of anti-muscarinic, umeclidinium, with vilanterol long-acting beta agonist. So that's, again, most of the combinations up until then, like your Advair products, were all inhaled corticosteroid, long-acting beta agonist. This is the first one to say, hey, why don't we give 2 bronchodilators into one? And not a novel concept. Albuterol and ipratropium has been in combination for years. That's the first people to do it in long-acting form, mostly for COPD patients. All right. Talked about these already. There's just a diagram of them. Nebulizers, I'm not going to go. You can watch these videos on your own. They're kind of funny, but for the sake of time. There's one where there's this little kid walking around in the background kind of photobombing the whole thing. That's somewhat entertaining. But it just shows how a nebulizer works. A nebulizer is just a machine that basically vaporizes, well, nebulizes it, right? But I use the term vaporize because people understand what that means more. It creates a fine mist out of a liquid. You can nebulize any liquid. So the cool thing about nebulizing or atomizing something is, like, you could put an IV product into a nebulizer and have somebody inhale it that way if you wanted to. So there's a lot of cool applications to nebulizers. Certainly there's certain products designed for nebulization. So I think I mentioned on a couple of these slides here. So for example, you have Pulmicort or budesonide comes as a nebulizer. It's the only corticosteroid on the market that's in nebulizer form. Great for little kids with asthma. And then you have a drug called Brovana or arformoterol, which is a nebulizer-only long-acting beta agonist. So you do have some options for either kids who are using them or adults who for some reason can't use an inhaler. you do have a couple alternatives there. So remember nebs, just in case your patient's having a lot of compliance issues, especially if they're like an older adult patient and they have caregivers. Nebs can be a really convenient option for people to just put on. They can breathe, they can watch TV, or do other things while they're doing it. Usually takes about 10 to 15 minutes for a full neb treatment. And nebs are a little bit interesting if you compare the doses. I wonder if to have the dose of albuterol on here. Oh yeah, so there's this little bullet point in here that probably didn't make sense at first, but the reason I put this in there is because if you inhale an entire nebulizer vial of albuterol, you're getting about 2,500 micrograms of product versus each actuation of this. So each time I spray this, I get 90 micrograms. So if you think about it, if you go in and you're having an asthma exacerbation, you go in the ambulance or the ED or whatever, they hook you up to a neb machine. You aren't going to inhale all of that because you'd have to be breathing it in constantly, but you're going to inhale quite a bit of it. Let's say you inhale 1 milligram of it. That's still 1,000 micrograms. You know, you'd have to get 10 puffs to get close to that. So my point in saying that is when you're looking at people using rescue inhalers, a lot of times the instructions will say 1 to 2 puffs every 6 hours as needed. You could do like 10 to 20 in an asthma exacerbation and still be within like the realm of normal dosing for what you'd get in a nebulizer. So it's okay for patients to go above that in a exacerbation. I wouldn't say maybe do that all the time. That's a bad idea. But if they're having real difficulty breathing and they're waiting for EMS or whatever it might be, they can keep puffing on this. Worst case scenario, they get really tachycardic, but we can handle that too. So it'll wear off. But just my point is that the dose is drastically different between the two, but you're still inhaling it the same way, basically. Yeah.
Do you use nebulizers as a way to get past the expensive delivery devices? So basically you can kind of make your own cocktails or cocktails?
Kind of. What's common, and especially in uncontrolled COPD patients, a lot of times they just do almost round-the-clock nebs where they do albuterol ipratropium combination every 6 hours, like daily, so 4 times a day. It's not ideal, but it's probably going to be more sustained effect than it's like they failed inhalers. They're probably on oxygen at that point too, sort of end-stage COPD. But yeah, we do see that. We see that sometimes in nursing home patients and people who have access to care like that as well, where they can do that. Sometimes like in the hospital, our RTs can do continuous albuterol nebulizations where they basically hook it up to a syringe pump. So they fill up a big syringe full of albuterol liquid and then they hook it up to a pump that slowly releases it into a nebulizer. So it's constantly nebulizing over however long they want to set it. Now that's not really cost, but certainly on the outpatient side, if you're doing the 4 times a day nebs, like I said, are really cheap. A nebulizer machine, like when I had to buy one for my daughter, it was like $25 at the pharmacy. So that really, really cheap. Like it's crazy that machine costs less than a single plastic inhaler. So yeah, it's definitely a cost savings option. Is it ideal for most people? No, but for some people it might actually make a lot of sense. So yeah, it's a good point. Okay. Talk about a couple other drugs quickly before we get into the guidelines. Drugs that affect lipoxygenase or LOX. You have a couple options here. These are going to work slowly. They aren't really great for acute situations, but they do have an onset of a few hours. So sometimes we'll talk about exercise-induced asthma. So you can use them kind of like pre-acute situation. If you always get, I don't know, if you're going to go for a long run and you feel like you get allergies certain times of the year, some people will take these a few hours before they go for a run, and that can sometimes suppress the allergic response. Basically, that's the design for these, is they work for asthmatics and for people who have allergy-related asthma. They don't really have a lot of effects in COPD or other respiratory diseases, so they're kind of limited. But they do have a good long-standing history of efficacy behind them. Singular, or which is now generic, it's Montelukast is the generic name. It's a once-daily medication approved for pediatric use. It's going to be the most common one you'll see. It's a really popular choice. A lot of people take it at bedtime. It tends to make people just a little bit sleepy, but again, once daily. There's also a drug called Zafirlukast or Accolade, which is a newer one that's twice daily. It's a little bit more expensive. I think it is still brand name too. So you would always start with Montelukast in most patients. Accolade's probably something you would go to if it didn't work or you wanted to escalate therapy. You'd do the Zafirlukast. There's also a product called Xyluton or Zyflo, which is a twice daily oral medication that it's kind of confusing because it's called Zyfil. It sounds like an inhaler. It's not. But that one, I've never seen this prescribed, so I don't know if it's popular or not, or in certain populations or what, but not the ones I see, I guess. So Zafirlukast and Montelukast I do see a fair amount. Montelukast especially is a really common medication. Xanthine derivatives, also known as direct bronchodilators. We don't really know how they work. Caffeine is an example of a xanthine derivative, or a methylxanthine. There's not really a clinical significant use that I can think of. You can use these in like a really bad asthma exacerbation if nothing else is working. However, I've never had to use them in my career, and I've seen a lot of asthma exacerbations. There's a lot of other options that just work better. So again, it's an option, but I just don't really see the purpose of it, so I'm not going to test you on it directly. We'll talk about caffeine, especially in pediatrics, a little bit more with respect to using it in premature infants. Sometimes they use caffeine to help open up the airways a little bit, and it works really well in kids. But theophylline's got a lot of issues with it. You can't use it for a long period of time. It's really toxic. It's got a lot of drug-related interactions too. So again, it's something you might see somebody on orally if they've tried everything else. So maybe they're on 3 inhalers, max doses, and they still have COPD related issues or still are having asthma or something like that. You could maybe try oral theophylline, but I rarely ever see it given IV. It's pretty uncommon. And then Xolair. So Xolair is a MABS. It's the monoclonal antibody. It's IgG monoclonal antibody that inhibits IgE binding on mast cells and basophils, so it limits the activation and release of allergic response mediators. So this is somebody who has allergic asthma, it's not controlled on other things, or just wants something that's a little bit more simplified. So maybe nothing's really working for them, and they try this product. This is really expensive. It's about $1,000 a dose. You dose it every 4 weeks. And it's not studied in kids less than 12, which is probably a population where it could be useful, but you might see pediatric use off-label for it just because it's relatively safe. It does have a increased, like all monoclonal antibodies or any biologic product, you have an increased risk of anaphylaxis compared to oral medications or any other type of small molecule drug. And so most people, if they do get it, will occur in less than 60 minutes after the first or second dose. So for those patients, keep an eye on them for an hour. Otherwise, it's kind of a specialty item, but it is something that is used, I feel like, more and more. We're seeing it commonly, especially for those people with really bad asthma that's very associated with a specific type of allergy. All right, let's talk about the asthma guidelines, and we'll take a quick break. Global Initiative in Asthma, or GINA, is the asthma guidelines, I should say. In case you want to look at them on your own. The basics of asthma, so you have a chronic inflammatory disorder of the airways, waxing and waning airflow obstruction, and bronchial hyperresponsiveness. Affects about 7% of the U.S. population. It's one of the most common childhood illnesses and responsible for a lot of hospitalizations. It's very preventable, and death is extremely rare. I've never even, should I say never? I don't think I've ever seen somebody get intubated or have to get mechanically ventilated from an asthma exacerbation. I've even had patients come into our emergency department with starting an exacerbation and say, I always have to get intubated. You might as well just go there now, just sedate me. Nope, we're gonna work with you and figure it out, because you don't want to intubate somebody if you don't have to. And if you do all the right steps with asthma, you really shouldn't. And if you manage it correctly in the outpatient, you should prevent the hospitalizations to begin with. So again, very preventable illness, but certainly scary and possibly deadly if not treated correctly. All right, so you guys know this. I don't need to show you pictures, but there it is for the sake of talking about it. Triggers, household allergens, workplace-specific outdoor allergens, some other medications I have listed there, and nothing I'm concerned about you knowing for my class, stuff to know in general. Sure, if you have somebody with asthma, it's important to work through these things and figure out maybe what's the root cause and can you eliminate something from this list. Our goal is we want to reduce impairment, so impairment from intensity and frequency of symptoms, freedom of cough, chest tightness, wheezing, shortness of breath, sleep disturbance, minimize use of that rescue albuterol or leave albuterol, optimize lung function, maintain normal daily activities, and then prevent hospital ER visits, prevent lung growth reduction, things like that. As far as classifying asthma, I don't really care you know how to classify asthma from my perspective. What I would like you to know is just have a general understanding for some of the more concepts here as far as like drug-related things. So for example, I've already talked about this, but people who don't use their short-acting beta agonists very often have better overall asthma profile. If we go up in severity, you can see you're using it several times a day or daily. There's some other things on here that are more common sense type stuff like normal activity. You've got all the pulmonary function tests, which I don't care you know for my exam either. You probably have a module all about this stuff on its own. I'm not going to retest you on any of that stuff. So I might give you pulmonary function tests just as part of a case, but I'll always give you a classification for how I want you to score. And asthma doesn't really matter because it's more of a step type system. COPD is more based on what type of criteria you fall into, so we'll talk about that separately. All right. So let's spend a few seconds on the guidelines. So this is a slide that's really sort of the meat and potatoes of this lecture and as far as clinical testable material. So the big change for 2019, which was a pretty huge change compared to what it's been, the guidelines haven't really changed for multiple years, but and the first step was always to just start with an as needed short-acting beta agonist. So if your asthma was reasonably controlled, you would just give somebody here's your PRN albuterol prescription, use it if you need it, otherwise you don't need anything. Now what they're finding out is that there's been some studies that show that if you do have an exacerbation and you take a low-dose combination of formoterol with an inhaled corticosteroid right off the bat, you see a better lasting benefit for the person not having a rebound exacerbation, not having to use excess medication, better side effect profile tolerance, and less tachycardia and jitteriness. So that's, again, the big change for 2019. If you'll see this translate to practice, I'm not entirely sure because I don't practice in peds, one thing, I don't practice in outpatient respiratory medicine. But I'll be interested to see if we see more of this type of prescribing going forward. I still think the school of thought is more like don't start a controller medication until you have confirmed that they're using their rescue inhaler. Maybe like if you go back to this, are they using it more than 2 days a week? That's maybe a time to think about, let's increase their plan here and go up a step. But again, so they're recommending to use the low dose inhaled corticosteroid formoterol, and then they do say that you could have an as-needed short-acting as well. So the question is, if you give them this low-dose ICS formoterol combination, do you still need an inhaled short-acting beta agonist? And that's up to you. I don't think you would, because you would be having them use this PRN. But what if they use it 5 times a day? Is that too much? Because most people would only take it twice a day. So there's a lot of questions with here that I don't think the guidelines do a great job at answering. But anyway, they're kind of going with a new strategy. It makes sense clinically, I think, to give something long-acting that works quickly. And ever since formoterols came out, they've always talked about it being useful for a short-acting in a pinch. Like if you're going to give somebody, and somebody's like, I'm not carrying 2 inhalers with me, I'm only going to carry 1, I don't care what you do. Well, okay, I'll give you a product with formoterol because you could use it as a short-acting product in a pinch if you needed it. And so I think that's where some of this has started to happen. So anyway, basically you're looking at those 2 products, Dulera or Symbicort, as the 2 with formoterol in them and the combinations there. Formoterol doesn't come as a single product, and in asthma we don't use long-acting beta agonists by themselves ever. There's actually increased mortality risk with just a long-acting beta agonist, so they always have to be used in combination with corticosteroid for an asthmatic patient. So the big difference in COPD and asthma, COPD you can use a long-acting beta agonist on its own. So here, what they're saying is you have your as-needed low-dose ICS formoterol. If you do need to step up, it's really the same as the guidelines have always been. So in asthma, you start with a low-dose inhaled corticosteroid, and then you work your way up with daily regimen after that. They do say to keep on this as-needed product throughout the whole stay, though. So that's always going to be your as-needed thing, which is kind of interesting. I did talk about inhaler price. One of the implications of this is Dulera and Symbicort are 2 of those $200 to $300 pop inhalers. So you're going to give somebody an inhaler that is only good for 6 weeks once you take it out of a package that costs $300 versus an albuterol that's good for like a year or 2 out of its package that costs $20. So big cost implications with some of this here. For people who don't have insurance, yeah, I don't know if they're going to be able to really afford this type of a plan, but again, this is what the guidelines are recommending, so that's what I'm telling you. So anyway, after you start, so you always start on the low dose inhaled corticosteroid is your daily therapy. So you've got two different things we're talking about here. You've got as needed and controller. Your controller medication is the thing you take every day, and that's where you start with low dose inhaled corticosteroid, and then you would go to a low dose inhaled corticosteroid long-acting beta agonist. If you didn't get control on that, you would increase the dose of the corticosteroid. After that, you could increase it again if possible. Then they recommend adding on other things. The guidelines used to recommend that you could, at the very end here, add on an antimuscarinic agent. So you could do triple therapy with all the 3 inhaled products we have. They don't really have this on here anymore. They do leave it as like an add-on thing, tiotropium potentially. So there's your antimuscarinic. So the point is, in asthma, you can get to the point where you're using all 3 inhalers if you do have, like, if you aren't meeting your goals with any of these other options. But overall, most asthmatic patients are going to be managed pretty well with just that inhaled corticosteroid, maybe with the combination inhaled corticosteroid long-acting beta agonist. The muscarinic agent, in your head, you should really think of that as primarily a COPD product. However, again, you could use it for asthma for really severe cases. All right. So if you prescribe somebody a short-acting beta agonist, an albuterol inhaler for step 1, is that wrong? Is that the question? I don't think so, and I don't think the guidelines would say you're wrong. I think they're saying that there's better evidence to prescribe this combination as a PRN. And again, that's very new recommendations.
So you're testing this over the week?
I will test on the current guidelines, yes, but I would
Our
make.
other class is testing us on the old.
I never test on old guidelines. But doesn't mean I couldn't ask a question. Like I might say, patient has tried inhaled corticosteroid, which would, as a PRN, which would be an alternative for cost savings, and then you could pick the regular albuterol. So I could give you a scenario where they wouldn't be able to, or wouldn't meet criteria to use the preferred one. If that makes sense. But I'd make that pretty clear. So sorry for the inconsistency, class to class, but I mean, when you go out, you want to have the most up-to-date guidelines in your head, in my opinion. So, yes.
How are step 2 and step 3 any different from low dose?
So you've got a daily inhaled corticosteroid beta agonist versus a daily just inhaled corticosteroid. So this would be like once daily fluticasone. This would be once daily fluticasone with salmeterol combination. And then you're just increasing the corticosteroid dose after that, stepwise. So what I'll give you for a test question about an asthma patient is I'll give you, so I want you to know like what's within the step. I might give you somebody and I say they're on as needed low dose, what is the, I can't remember, what's in Dulera, I don't know, mometasone I think, mometasone formoterol, and it's not controlling, they've been using it 5 times a week, you're thinking about adding a controller medication on, which one would be the best choice? And then my choices would be probably a combination of different respiratory agents. You'd have to know out of those 4 which one's an inhaled corticosteroid, because that's knowing that that's the correct choice to put somebody on. And then, yeah, which one would be appropriate for respiratory use. Hint, I generally always use fluticasone. Give you a little gimme there. Okay. Any other questions about asthma? Really, it's not much different than the current guidelines. It is just this little caveat thing. So I don't think it's, as far as studying perspective goes between classes, I hope it's not too confusing, but just know that this is a guideline recommendation for this new thing, and you're going to see this incorporated into practice probably right now. All right. Exercise-induced asthma. More correctly, bronchoconstriction starts 6 to 8 minutes after exercise, resolves after 1 hour. Pretty straightforward what we can do. Beta agonists are the common prophylaxis to this, so people who get this will oftentimes use either albuterol or a formoterol ICS combo product 10 minutes before exercise, and that usually prevents exercise-induced asthma. You can get tolerance to the longer-acting agents, is what they've seen for people who use exercise-induced formoterol PRN. So albuterol tends to be what people prefer, and most people aren't exercising for more than 4 to 6 hours, so it should have enough of a duration. I guess if you're running a marathon or something like that, that's different, but you could always redose the albuterol while you're exercising if you needed to. There's no problem with that. Steroids, only use if poor asthma control is responsible. So if somebody is getting, if somebody's asthma is somewhat controlled and they exercise a lot, they always get exercise-induced exacerbations on top of their existing asthma, that's when you would want to manage the asthma component first. So hopefully this makes sense that you would basically treat the asthma, and that would hopefully take care of your exercise-induced component as well. Anti-leukotriene agents, again, for people with allergies, taking it a couple hours before exercising can help. So you take montelukast 2 hours before you're going to go for a run, and that might help with the exercise-induced exacerbation component there. All right. Muscarinic agents, no role, not studied. I'm not going to talk about asthma exacerbation too much right now. I want to come back to it during emergency medicine next summer and talk about it in more detail. So I'm not going to test you on it, but just so you know, this is sort of the treatment algorithm and what we can do. It's basically using the bronchodilators in a nebulizer form, our short-acting ones, albuterol, ipratropium, and then oxygen. We usually give steroids too, so IV methylprednisolone is common. And magnesium sulfate's one we can give IV as well. Magnesium acts as a smooth muscle bronchodilator when you give it in big doses, and people tolerate it pretty well, so that's kind of the final step there. And then if they are having anaphylaxis or something, that's a different pathway. So you want to make sure you get the epinephrine and those types of things on too. But yeah, the goal is to give them the kitchen sink and prevent sticking a tube down their throat. If you can do that, you're probably in good shape. All this stuff is acute. None of it has a ton of side effects with it, and we can manage them if they do come up. So anyway, just for the purpose of this exam, I'd much rather have you know the exercise-induced components, and then this is just kind of an FYI. We'll come back to it next summer and talk about it more. But I wanted to give it to you here just for completeness sake. All right, let's take just, do you want me to just finish or take a break? Just finish?
Finish.
Finish. I can power through it. There's only a few slides left. Okay, GOLD, COPD. The GOLD guidelines are the COPD guidelines, which is what I'm teaching off of. Not a whole lot of changes from last year, but I do have, again, the 2019 update here. A little bit different. So COPD basics, so this affects more than 5% of the population. High morbidity and mortality, third ranked cause of death in the U.S. If you work with internal medicine or general adult medicine, you're going to see tons and tons of COPD. If you work with patients that smoke a lot, like I did a bunch of rotations at the Minneapolis VA, like everyone had COPD. I mean, just high smoking population for whatever reason. High resource utilizations, frequent clinic visits, chronic medication costs, oxygen therapy. Multidisciplinary involvement. You have respiratory therapy, you have pharmacy, you have obviously the provider themselves, multiple providers in some cases. There are some causes like reduced lung growth and premature accelerated lung function decline, but the vast majority of people with COPD are COPDers because they smoke or smoked at some point in their life. Other causes, maybe environmental exposures if they work in like a chemical factory or something. I don't know, I'm just kind of making stuff up. Genetics, potentially too, but again, cigarette smoking by far the biggest cause of COPD. Just to show you a pulmonary function test with aging, your FEV1 goes down naturally as you age. This green line is your theoretical, or sorry, the blue would be reduced lung growth. So this would be somebody who maybe had like premature lung development that never fully recovered maybe. They just never get quite to the same percentage as somebody of their peer group who doesn't have the same problem. The green curve would be somebody with premature lung decline. So this would be like a smoker, and how eventually they're going to kind of meet the same criteria or meet the same function test as the person with kind of a genetic or a, I don't know what you'd say, what am I trying to say, at birth. That's the term. Congenital, thank you. Congenital defect of some kind that caused them, or an early premature labor that had premature lung development associated with it. So the lungs can recover quite nicely, and this also shows that even if you, let's say you pick up smoking at age 40, which studies show virtually no one does, but let's say you did, you still do kind of get the decline on the same. It's actually more aggressive than it would be if you started in your teens or 20s. So most people won't see the effects of cigarette smoking on their pulmonary function, and this is not a huge difference, but over time it definitely becomes a more substantial problem. Not all people will develop COPD who smoke. Surprisingly enough, some people will be just fine, but a lot of people will, and certainly most COPDers you see are cigarette smokers, or were cigarette smokers at some point in their life. Oh, concentric circles. I don't care you know this for my test, but this just shows that, because I think when people get in head, they're like, oh, chronic obstructive, but isn't asthma kind of obstructive too? Yes. So asthma is restrictive, but it also has obstructive components to it too. And this just shows that everything's kind of related, from emphysema to asthma to COPD. They all have commonalities. So airway disease, when it comes down to it, from a medical management perspective, we're using all the same drugs, and they all tend to have effects in all the same conditions. So that's all I care about you knowing with that slide. COPD information, basically, you've got a standard set of 3 symptoms: dyspnea, chronic cough, and sputum production. So when we're treating people, we want to reduce all that from happening. Patients can present with sedentary lifestyle, and sometimes that may be that they're unaware of their limitations, and they might be just slowly adjusting their lifestyle accordingly. Maybe like 10 years ago, they used to go for walks daily, and now they just kind of notice that they get a little bit tired, and their lung function's very slowly dropping, and all of a sudden, they've got really bad COPD, and they didn't even really know it because they sort of adapted a sedentary lifestyle. That's a common presentation of COPDers. Respiratory symptoms, initially only on exertion is what people are going to experience. So they might think, well, I got out and I was moving around and I kind of got out of breath. Well, I must have been exercising. Well, maybe they got out of breath faster than they normally do. So those are things that people should be counseled to note, especially if there's been a long-term cigarette smoker and you're concerned about their lung function. Diagnosis can be confusing sometimes. COPD exacerbations can look a lot like a pneumonia, and they can look a lot like a heart failure exacerbation. So that's where imaging can come into play. Pulmonary function tests and things like that can come into play there. Our goal: preserve respiratory function via pharmacologic therapy, and then don't forget our non-pharm therapy. These things are all essential. Smoking cessation, if they haven't stopped already, make sure they've got adequate counseling or options available to them. We'll talk about smoking cessation next spring and the drugs we use there, but that's certainly an option for patients. Nicotine replacement therapy or whatever it may be. Other risk factors, if there's something obvious, if they live in a house where there's a lot of cigarette smoke and they aren't a smoker themselves, or they quit smoking and their partner still smokes, those are things to think about. Vaccination, pneumococcal vaccines and influenza vaccines have shown to have drastically solid mortality benefits in COPD patients compared to even the general population. Oxygen therapy and pulmonary rehabilitation are options too. Obviously not my expertise in those areas, but just throwing them on there. So we already talked about all the drugs, which is nice. You have a couple different groups that people with COPD are classified in. So again, this is right from the GOLD guidelines. So again, you've got some criteria on each side here. You've got exacerbations not leading to hospital administration, or exacerbations leading to hospitalization, or what they classify as a moderate exacerbation. So A and B would be better, C and D would be worse. So as the alphabet goes on, it's a worse prognosis and more severe COPD picture. Group A would just be a single bronchodilator is what you're going to start somebody on. So you're always going to start Group A patients on something long-acting. Now, what bronchodilator you start people on is a little bit debatable, but I think generally speaking, the evidence would point to a long-acting muscarinic antagonist. So a LAMA drug would be your preferred starting point in a COPD patient. And the reason being is you see Group C recognizes that you should have them on a LAMA already. So if you start them on a LAMA in Group A, you've already got covered basically for the entire thing until you get to Group D, believe it or not. So the long-acting muscarinic antagonist is recommended in Group B, which could be, they technically say either one, but at that point you want to consider the LAMA because it's got the preferred evidence. If you haven't started the LAMA, Group C says start the LAMA. So again, they're just rehyping that this has better evidence. And then finally, Group D has some combination therapy available to it. So LAMA plus LABA, you can add an inhaled corticosteroid at this point if you want, and do triple therapy. So you can kind of work around it. But basically, they don't have you do more than one therapy until you reach that Group D point, which is a little bit of a change. They used to say, I think Group C used to start combination LAMA-LABA therapy, but now they've pulled back on that recommendation this year. So maybe they haven't found the evidence supporting it. I'm not entirely sure. This slide's kind of confusing. But the point of it is that you are going to move people around in the categories based on how they respond to the medications and what types of symptoms they're having. So let's say somebody has dyspnea and they're on a LABA or a LAMA. If they're still having dyspneic response and they're using their inhalers correctly, everything looks good, you just add the one they aren't on. So you combine the therapy there. One of the things they found out with COPDers is sometimes if they end up on an ICS right away, so if you give them the steroid LAMA or LABA combination right off the bat. So let's say you're like, you've got COPD, it's not good. I want to start you on Advair or Breo or some LABA inhaled corticosteroid. Not really related, not a guideline recommendation per se, but it's been done for years. So a lot of providers will still think like this. So let's start right there. What they found out is sometimes people actually get more respiratory infections with this. So they're higher risk of pneumonia, higher risk of some of the other types of like just COPD related exacerbations aren't quite a full pneumonia, but still might have an infectious component to them. So those patients, if they're getting more dyspneic responses, sometimes they recommend actually converting that patient from the LABA-ICS combo to the LABA-LAMA combo. Now, that's a little bit more detail than I want you to know. I kind of want you to just focus on the basic guidelines, but just to talk about how people think through this and how the guidelines recommend you approach things.
I got a question.
Yeah, sorry.
No, so in Chem Med, we learned that for Group A, you're supposed to use like a SABA, SAMA, or a combo of both of them.
Oh yeah, I messed up. You're right. Yeah, sorry. Group A is the I confused myself. Yes, short acting for Group A, long acting for Group B. That's the difference. Yeah, they just don't call it a short acting, but that's basically their bronchodilator. Yep. Sorry about that. Okay, so and then ultimately you could kind of work your way to three-way combo therapy, but at the end of the day, it kind of depends on some of these considerations where you might nix the inhaled corticosteroid. Again, I don't want you to know that for my exam. That's a little bit advanced for what we want to talk about, I think, for this class. But at the end of the day, it's why they might copy that one off. And that's been a pretty significant change. The inhaled corticosteroid has been a pretty standard recommendation as a COPD therapy, and they haven't really recommended dropping it. And now they're finding evidence, again, for some of this. So if you have some of these criteria you're meeting, they might want to consider you stopping that inhaled corticosteroid, at least for temporary. Yeah.
It was just a little bit of confusion. So for Group A, is it a sub?
Yeah, Group A would be a PRN bronchodilator. It could be a SABA or a SAMA. So it could be albuterol, could be ipratropium, or it could be the combination albuterol ipratropium. But it would be as needed. It wouldn't be scheduled. All right. For exacerbations, you can see kind of a similar flow chart here. Again, all roads end up sort of leading to the triple therapy if you're still not getting controlled. So at the end of the day, they still recommend inhaled corticosteroids as an adjunct therapy, but just, again, meeting some of these criteria, you wouldn't use them. And then ultimately, you could add roflumilast, which we'll talk about here in a second. And then there is some evidence that azithromycin chronically might have a role in preventing exacerbations, although that's really controversial. So that's why it's a very last step on the guidelines. Okay, so which long-acting bronchodilator is better? If we go back to this slide, if you start somebody in Group B, you just says a long-acting bronchodilator. Okay, why do we want to start the LABA or the LAMA? And why does Group C recommend the LAMA? Well, that's because the most evidence out there show that they're both pretty effective, but one's a little bit better. It's a little bit conflicting, but the most recent trials, the most recent two largest head-to-head studies showed that the LAMA was favored over the LABA by different metrics. So there's a New England Journal study here I referenced that was one of the bigger landmark ones out there that said that tiotropium was more effective than salmeterol alone. Now, people get nitpicky with some of this stuff, and they're like, well, my patient's not on tiotropium or salmeterol, they're on umeclidinium, so what about that one? It's like, well, you kind of have to take it with a grain of salt as far as the differences. So you just sort of assume the class works as well as the evidence portrays it. I mean, we don't have large, high-quality clinical trials for every single drug we're studying, right? We don't have these big head-to-head ones to compare to. The companies that get them approved don't have to do that. So at the end of the day, we have to go with what we know. So we know that in some studies, in most studies, at least the majority of them out there, comparing LAMA versus LABA, you have LAMAs coming out a little bit ahead. So that's where the recommendation is. So for most COPDers, again, that's why I associate the antimuscarinics with COPD more so than asthma. Asthma, it's a very last line. COPD, it's pretty much the first line for a maintenance controller medication. What about glucocorticoid use? Glucocorticoid use is shown to decrease exacerbations and slow progression of respiratory symptoms. However, people with inhaled glucocorticoid use don't really show any improvement in lung function, pulmonary tests, or mortality benefits. So while it improves quality of life a little bit, it doesn't tend to reduce the overall disease, and that's the ultimate goal, is we'd reverse the damage to the lungs. We can't do that very well right now, but it seems like the bronchodilators are better at preventing decline versus the glucocorticoids just seem to help people's daily symptoms but don't actually prevent the decline of the lung function over time. So for that reason, we don't use ICS as monotherapy in COPD. So again, another big difference between COPD and asthma. ICS first line for your monotherapy, and you wouldn't use that as a monotherapy in a COPD. Combination glucocorticoid reduction in moderate to severe exacerbations. So the combination of glucocorticoid in addition to one of the bronchodilators, whether it's a LABA or a LAMA, has shown some decent evidence, again, to reducing exacerbations. Remember, the guidelines have included some criteria to say to get rid of them if, again, people meet certain things like pulmonary infections. But other than that, they do have a place in the guidelines. They just aren't a solo option. And then triple therapy. Triple therapy has some good evidence with it too. It's a logical place to go. You have 3 inhalers. If somebody's not getting better on 2, add the 3rd. And that's mostly the case here. The trials didn't really show did not reduce decline in FEV1, so pulmonary function overall wasn't declined, but they did show improved airflow, reduced exacerbations, and improved quality of life, which are all good metrics to meet. So again, that's a guideline recommendation to include them all as a single treatment arm. All right, refractory COPD. I talked about oral theophylline briefly, so this is something that they would start on somebody in addition to their inhalers. Usually don't pull the inhalers back, keep them on, and then you'd add the oral theophylline. Again, drug interactions, metabolic interactions, liver failure are things that can happen. So liver function tests would be an important monitoring thing with theophylline. And then there's a drug that's a PDE4 inhibitor. PDEs are phosphodiesterase enzymes. There's a bunch of different ones in the body. They all do kind of different things. The PDE4 inhibitors, or phosphodiesterase 4 is an enzyme specifically involved with activity of certain immune cells. So they made this drug as a once daily oral medication that decreases immune response within the pulmonary vasculature, which is sort of an interesting niche use of it. But it's really expensive, has been shown to improve FEV1. So you do see this used, say, relatively commonly in COPD patients, especially people who are on optimized inhaler therapy already and are still not getting the results we want. So they'll start them on roflumilast. And then finally, there's lung reduction surgery and lung transplant options for patients who just aren't responding or have lungs that are beyond repair at that point. We can only do so much with medications. Even if we throw oxygen therapy and pulmonary rehabilitation on there, again, we can only do so much with that. Sometimes lungs are too far gone or the progression's too severe and we won't be able to recover them. So we can make the symptoms better for a period of time, but ultimately somebody might need a more drastic intervention. COPD exacerbations, talk about this very briefly. Acute symptom increase, usually a respiratory infection. A lot of times it's viral causes, so rhinoviruses, influenza, big ones. Viral DNA is often found in sputum regardless of the exacerbation. Bacterial infections are less common but still possible. Usually it's more common to see bugs like Haemophilus influenzae and Moraxella catarrhalis versus strep pneumo, which is our more common pneumonia bug. But strep pneumo is possible. You just kind of flip the prevalence of them, whereas these ones aren't quite as common in pneumonia, and strep pneumo being the big one in pneumonia. Pseudomonas and more advanced gram-negative bugs are less common in COPD exacerbations, and you wouldn't treat anyone really empirically for that, but if somebody did have like maybe a lot of hospital exposure or something like that, you could consider it. Atypicals, less than 5% chance, which is kind of interesting based on what we use to treat them. But anyway, co-infection, combination of bacterial and viral pathogens is possible, and it's hard to rule that out. Usually with both of those at the same time, you're going to see an increased severity. And a lot of times it's hard to draw the line between this and a community-acquired pneumonia. They can look really similar, so it's a question of how aggressive you want to treat. Diagnostic tests would be sputum culture, but sputum cultures can grow all kinds of weird stuff, so it's hit or miss on whether you're going to get a pathogen out of that. Usually we're looking at oxygen. We're looking at short-acting drugs like PRN inhaler, nebs, continuous nebs, plus or minus the short-acting muscarinic antagonist, ipratropium. Systemic glucocorticoids, like I said with that already, you can use that as a burst therapy for people in COPD exacerbation. Xanthines, like theophylline, are not recommended in COPD exacerbations. They actually can make things worse. So if somebody's on theophylline chronically, you would hold it during their exacerbation until they improve. And then antibiotics. So really, it's a very similar treatment to our community-acquired pneumonia. Azithromycin is really commonly used as first line. I don't totally disagree with it. Azithromycin does cover Haemophilus and Moraxilla pretty well. Remember, it doesn't cover strep pneuma all that great, but its big role is in atypical management, which isn't a huge component of COPD exacerbation. So it's a little bit questionable to me. I would probably prefer doxy for the most part in patients for COPD exacerbation. It's going to get a bit more well-rounded coverage than Azithro. But you aren't wrong to describe Azithro. And Azithro is certainly really convenient for COPD exacerbations. You could go with the bigger guns, and basically at that point you're just getting into community-acquired pneumonia algorithm. So you give a fluoroquinolone, you give Augmentin, you could give third-generation cephalosporins, Bactrim. You really just don't need to worry about the atypical coverage. So if you're going to give a more advanced generation cephalosporin or a beta-lactam like Augmentin that's a little bit extended spectrum, then you don't need to cover it with azithromycin on top of it. That's the big difference between advanced COPD exacerbation and CAP. But again, the line gets really blurry, so would you just cover both just in case? Probably not a bad idea, but I'll leave that up to you guys. And then Pseudomonas, you'd want something bigger to treat them, or like at least levofloxacin to consider, which is really the only respiratory fluoroquinolone you'd consider for as monotherapy. Otherwise, you're looking at IV agents only. Okay, chronic antibiotics for prevention. You remember I said this is a little bit controversial. Scroll back to this. This is an option. In former smokers, as a subset of a clinical trial, they showed that former smokers responded to chronic azithromycin therapy and reduction of exacerbations. Problem with doing that is you're going to make them basically resistant for anything else with azithromycin, and over time, chronically, is it really going to have a huge benefit? That's the real question. Like if you take it for 10 years, I think the trial lasted 6 months or a year. So over a long period of time, does it eventually stop having an effect? We don't really know. But a couple things have been trialed. Both azithromycin and daily moxifloxacin was trialed. Moxifloxacin being quite broad spectrum, respiratory fluoroquinolone. Both of them showed generally that in the standard COPD subset population, there's not a huge advantage to using them, and ultimately people are more at risk from side effects, drug interactions, and then antimicrobial resistance. So we want to reserve it, but again, the guidelines would say that if you have somebody on everything else and they're a former smoker and they still having exacerbations, you could trial daily azithromycin. But that's a small, well, again, a lot of people would probably be former smokers, so maybe it's a larger group of people, but you'd have to use your clinical judgment on that one. And you might not see effects that you want to. You might not see anything at all. Okay, that's the last slide. Any questions on COPD management in general? Back to these. So yeah, just so I can repeat myself and say it correctly. Group A, start with the bronchodilator, and it's going to be an as-needed, short-acting product, whether it's single albuterol, single ipratropium, or the combination albuterol-ipratropium. It's going to be a short-acting, as-needed product. It's not going to be chronic, or not round the clock. So. All right. So for the exam, again, we have a certain sub-blocks of stuff to consider. Do you guys have any things you want me to review? Anything that you didn't think was clear from last week's material or the previous week's? Remember, the second chemotherapy lecture is not covered at all. First chemotherapy is basic stuff, some basic things I covered in it. Some mechanism of action, cell cycle type questions mostly. A couple side effect questions, but I think I highlighted some that I thought were important during the lecture. So.
Did you check into the possibility of putting up dates next to the lectures?
I didn't. I guess I've never had an issue with it before, and I've always had it the same template. So I don't put.
It's like on noodles, like list it somewhere, you said the date and election.
I can try. Yeah. Yeah. No. Okay. Anything else? All right.
Thank you.